Hello and welcome to a special episode of Checking the Vitals as we continue to cover the COVID-19 outbreak. I am your host, Todd Schlosser, and today our guest is Kirti Patel, the National Clinical Specialist for Perfusion at SpecialtyCare. In this episode, we discuss how the COVID-19 outbreak is impacting the Houston area where Kirti is located. We also discuss in detail what ECMO is, why a patient might need to be placed on ECMO, and how it is the last line of defense in someone's fight against COVID-19. We also discuss some uplifting things that are happening in the Houston community to help these frontline employees at the hospitals feel supported as they fight this COVID-19 outbreak. Enjoy the conversation. So Kirti, thank you so much for taking the time to join us today here on Checking the Vitals. I would really like to start out with, sort of like I started out with Courtney on our special episode yesterday, and just really seeing what things are like on the ground in Texas where you are, because she was from Denver yesterday, and I'd love to see how things are similar and possibly different in Texas where you are.
Yeah, absolutely. In Texas, I'm based out of Houston, and as most people are aware, Houston, our Texas Medical Center is one of the world's biggest med center, actually in the world.
Yeah.
So we're going to see a huge influx of patients with COVID-19 for sure. We already are seeing that. A lot of some of the hospitals locally are already maxing out on ICU space because of COVID-19 patients.
Yeah.
And so it's challenging times for sure, unprecedented times for sure. But what's great, is that you really see all these hospitals in the medical center coming together and developing algorithms and different management protocols to treat these patients. We're not, in this kind of situation, none of these hospitals standing alone, even though they're competitors, they're not standing alone. They're collaborating, they're working together and trying to figure out how to best treat these patients. And not only that, but also how they can protect healthcare workers, because obviously, we're on the front lines and we need everyone as much as possible to be available to take care of these patients. And so trying to keep them safe is also extremely important.
Once heard someone say that in times of crisis, no one is siloed. And it does seem like you attested to there in Houston in your medical center, all of those competitor hospitals are working together to make sure everyone is safe and just do everything they can for the patients. So have you guys in Houston seen the influx of COVID patients like New York has?
I think we're just beginning to, we're just on the upslope of this curve.
Right.
I think New York is already kind of on this high end of the slope. I don't think half of the cases in this country are based out of New York.
Yeah.
I think the last time I checked, we're approaching 100,000 cases.
I think we passed it last night.
Confirmed. Yeah. And, almost half of that is in New York. So, I think here in Texas and across a lot of these other states, I think we're just beginning to see this influx of cases. Testing is still an issue. We're not testing everyone that's symptomatic, and that's an issue. So, we haven't taken an aggressive measure with this as yet as a nation. And I think that's a problem. But for Texas, I think we're just starting. I see the next 4 to possibly 8 weeks where the numbers are actually going to start peaking. So we're just beginning on facing some of these challenges that New York is facing.
Yeah. Now, you guys in Houston, are you seeing shortening of supplies of things like N95 masks or ventilators or things like that?
As far as ventilators, we aren't quite there yet. The concern's there, and obviously we're not in the situation like New York is.
Sure.
But as far as, PPE equipment, yeah, those are in short supply. And, we're coming up with ways of trying to ration them. A lot of my wife's also a nurse, and, she actually has a little container that the hospital gave her how to keep her N95 mask. And they get to keep this one mask that they use, until it's soiled. And it could be, a week, it could be 2 weeks. So,
okay.
they're really rationing N95 masks, But again, fortunately for states like Texas and other states where we're just beginning to see that, we are hopeful that we will have the supply when the time becomes very critical. I think there's a lot of companies out there, 3M, and
Yeah.
so there's a lot of companies trying to work on getting a huge supply of N95 and other PPE equipment to hospitals. So I'm very hopeful that not everybody is going to be facing those issues when they have this influx of cases in their particular location. But
Absolutely.
again, absolutely is an issue already. Some of the hospitals may have supplies that are read locally. Some of them have regular surgical mask supply for next 15 days, and that's it. And
Yeah.
that's alarming. We're using some of these masks hundreds, thousands a day. So certainly an issue, because if we can't stay healthy and be protecting our healthcare workers, how are we going to take care of these patients? So it's certainly a top item agenda for all hospital systems here in Texas and across the nation.
Oh, yeah. And I know a lot of, well, even at the federal level, although the federal level is usually slower than like the state level, I know a lot of state level governments across the U.S. have been doing whatever they could to get ventilators and get PPE equipment such as masks and scrubs and the face shields, right, to protect the frontline employees in these hospitals. Because really, like you said, if our whole frontline medical support system goes out sick for COVID-19, there's no one there to help. So we've really got to do everything we can to protect those people. And you've seen a lot of companies like 3M. I even heard some stories about in LA specifically, some TV shows who were shut down were donating ones that they had purchased for filming purposes that they just didn't need. So they just were giving them to the hospitals in the area. So people around the country are finding creative solutions to fill these gaps while the local and federal governments are sort of trying to fill the pipeline of more protective equipment, which is great. So
absolutely.
I would like to shift, if we could, because we talked to Courtney yesterday, and she was talking about how some patients are needing to go on to ECMO, and I just didn't follow up with her as much as I wanted to about exactly what ECMO is, why someone would need to go on it, and I had some follow-up questions if I could ask you those. So let's start with, what is ECMO, and why would a patient need to go on it?
Okay, so ECMO basically stands for extracorporeal membrane oxygenation.
Mm-hmm.
And, when you just talk about ECMO, there's two forms of ECMO, whether it's a VA ECMO, which is a veno-arterial ECMO.
Mm-hmm.
These are ECMOs that are placed in patients that that have a cardiac component associated with them. And so they need cardiac support. Also the lung support, obviously, because the heart's not working.
Right.
And then you have VV ECMO, which is venous ECMO, where you're assuming that cardiac function is intact. And that's a requirement to put patients on VV ECMO. So on these COVID-19 patients, you're seeing patients coming in with a lot of respiratory issues. And so, if you look at any algorithm of a hospital, one of the bottom things that you'll see on that algorithm flowchart is you're going to see ECMO. And that's kind of the last therapeutic, mode we have of trying to save these patients. And so in VV ECMO, what we do is we actually put two catheters in a patient.
Okay.
Basically, you could call these tubes if you want, and they both go in they could be put in the neck in the IJ position, intrajugular vein, or most of these patients, we're putting them on femoral VV ECMO. And so basically in one leg you have a catheter and in another leg you have a catheter. So what you're doing is you're draining the patient's venous blood into a circuit that has a oxygenator and a pump. And so this blood comes in through the right side of the heart, through the cannula, into the circuit, gets oxygenated through the oxygenator, and then warm the patient up too. It's got a built-in heat exchanger. So we try to keep these patients kind of normothermic, and then it returns it back to the patient at the level of the right atrium, so that now what you're doing is you're basically bypassing the lungs. So you're basically taking the function of the lung using an external, it's almost like a heart-lung machine, but in a very smaller version of it.
Okay.
Blood comes into it, then we pump it back into the right side of the heart, where the heart literally takes over that oxygenated blood and pumps it to the rest of the body. That's why you need an intact
cardiovascular system.
Correct.
Yeah. So let me ask this. I mean, the patient's still breathing while this is going on, and is it just sort of giving their lungs a break?
Yeah. So what you do is, these patients are, one of the things about ARDS. So ARDS, acute respiratory distress syndrome, that a lot of
Right.
these patients face. And so what happens is in this, when you put these patients on a ventilator, the ventilator is a great strategy of helping these patients. However, it's a double-ended sword because these patients that already have a lot of lung injury, having high ventilator settings actually injures the lung furthermore. And
Oh,
so
wow.
what we call this is called barotrauma. It's a further barotrauma injury that they get. So what we try to do is once we put them on ECMO, we try to decrease the ventilator settings and let the ECMO do most of the work. So, when you start talking about ARDS and ECMO, the term we use is, protective ventilator strategies. And this is where we try to minimize what the vent is doing so that we let the lungs rest and let the ECMO do majority of the work.
Okay. So let me ask this, and obviously I'm assuming, and correct me if I'm wrong, clearly, but a doctor would say, okay, this patient needs to go on ECMO, right? And then we have a perfusionist come in and sort of set them up on an ECMO circuit. What does it take for a patient to get there? Clearly, this is not the first line of defense. When they come in with symptoms, maybe shortness of breath, or maybe it's just hard for them to breathe, there are a few steps before then. What are those steps before we would need to put someone on ECMO?
Well, you have a patient that comes in, they are not intubated, they're in room air, they'll put them on nasal cannula, and eventually end up on a ventilator. And now they've maxed out on the ventilator where the settings are extremely high, and they're still not able to get adequate oxygenation on these patients. So when these patients, oxygen levels in their blood are extremely low, then depending on the physician and institution, they may have a target PO2 level in the blood that they'll say, okay, beyond this, we're going to go to ECMO. And of course, they're looking at other things as comorbidities, is how old is the patient?
Sure.
Are they underlying conditions, cardiac issues, cancer, age, or history of stroke? All those kinds of things go into decision making.
Right.
But once they make that decision, it's usually because the ventilator wasn't enough to provide them life-sustaining oxygenation.
So this may be a question that just no one can answer at this point because everything is so new, but I'd imagine it's a very small subset of people that actually catch COVID-19 that need to end up on ECMO or even a ventilator. Do you have any idea about what those numbers would be?
We don't really have really good data yet. It seems like ECMO has not been utilized. This is information from China.
Yeah.
Again, resources is a question that remains to be answered, and what kind of resources were available for them for as far as ECMO. But we can literally put any of these patients on ECMO. The problem is, how many ECMO machines are in the country?
Right.
Every single institution, depending on their size, may small institutions may not have any. A large institution where I'm employed, we could easily put at least 8 ECMOs and possibly be able to, rig things up to provide ECMO support on an additional, 5 or 6 other patients. So, we could potentially provide ECMO for 15 patients, but
Right.
not all hospitals are able to do this. So, and the data that we have out there on success, there are reports, I've read reports where, mortality is extremely high in these patients that are COVID-19 that end up on ECMO. But then I've also seen data that says there's 90% success rate.
Yeah, it seems like it's just so new at this point that, some hospitals are seeing a lot of success with it, some aren't. And it's just there's not enough data to really determine a figure at this point.
Absolutely. Yeah. This is so new, and trying, us as medical professionals, we rely on, data and studies, and a lot of these things takes years and years and years before we actually implement. We're dealing with infection that's been around for 3-4 months, and trying to come up with guidelines based on experience, and it becomes very difficult.
Absolutely.
To figure out what's best and what's right. So it's definitely ongoing challenges on what we should do and what we should not do.
Speaking specifically to supply of these ECMO machines, you mentioned you could probably service 15 patients on an ECMO machine, but from what I understand, someone could be on ECMO for 3, 4, 5 weeks. So So is that
Absolutely.
also a concern? How does that shortened supply become a concern? Like, what do you do in those situations?
Yeah, I mean, it's tough, because you're right. When you put these patients on, you're committing for a long-term recovery, if there is recovery, and 3-4 weeks is not uncommon. We've done ECMOs VV for ARDS on patients for 6 months before,
Oh, wow.
and so and people have done them even longer.
Yeah.
So resource commitment is huge. And once you put these patients on ECMO, you also need the personnel for ECMO. Fortunately, I'm in a big institution where we have a lot of perfusionists. We also have resources, ECMO specialists available to us that help us manage these patients on a day-to-day basis.
Right.
But if you're dealing with an account where there's 5 perfusionists and you have ECMOs, possibly in 2 locations, how do you manage that? Because now, if you have a perfusion team managing that, it becomes extremely difficult. Managing these patients.
Are there other people in the hospital that can run ECMO machines other than perfusionists? I was under the impression that it was just perfusionists that ran ECMO machines.
So we have actually a group of trained ECMO specialists in-house, and most of these are actually they're registered nurses that typically take care of ICU patients.
Okay.
So they kind of go in and out of rotation depending on needs. But at this time, almost all our ECMO specialists are assisting in bedside monitoring. Perfusionists initiate all the ECMOs. We're there for all the circuit changes. We're there for any transport that's needed and things like that. So, but having ECMO specialists really, really helps the staffing. Because just even though we're doing urgent cases or emergent cases only, because of the size of our institution, we do have a lot of cases still ongoing during this time because we do lung transplants and heart transplants and liver transplants. So we may still have 3 or 4 or 5 ORs going at any given time. So resource becomes important when you're dealing with high number of ECMO patients.
That's a good thought too. I mean, a lot of people, I guess, just assume, every element of the hospital is going to be there to service the COVID patients, but there are so many other emergency procedures that go on in a hospital that is not COVID related. So, all of those surgeries that, are considered elective may not be done, but you still have people who come in and need surgeries immediately for other emergency purposes, and they might need a heart-lung machine that requires a perfusionist. So that drains the supply of personnel, right? So
absolutely.
What do you guys do in those situations? Like you mentioned you guys have a big team there, so maybe you guys won't run into this, but if you have a lot of perfusion stretched thin with the need for ECMO, and then these emergency surgeries come up, how do you guys handle that in your area?
Yeah, and that's the thing is, small institutions, those are some of the tough decisions they have to make. It's
Yeah.
like, so all that has to be kind of discussed ahead of time, and you have to set a limit on how many patients are going to be on ECMO, and then also really logistics becomes very important. Are you going to have all these patients in one area? We've created a unit that we call highly infectious unit, and pretty much having all our ECMO, all our COVID patients in that area, so that if they do need to go on ECMO, then it can be easily managed on a single floor, so that you're not tying up resources,
right, in traveling back and forth. Yeah,
absolutely, and also just the spread of the infection across the hospital. That helps limit that. But we have 10, 12, 10, 11 ORs. We could convert all those heart-lung machines into ECMO if we have to. But again, like I stated, what if we do have a liver transplant? What if we do have a lung transplant? What if we do have a heart transplant? And we're a level 1 trauma hospital, and what if I get a type 1 dissection in the middle of the night? There are days when we've had 3 type 1 dissections, which are which are emergent cases and long emergent cases. So, we're prepared for any of that just because we have a big team. We're also kind of been very flexible in how we're doing things. We're trying to keep minimal traffic in and out of the hospital. So our team has actually gone on a different schedule, and where we're doing half the team's doing 7 days straight, and the other team is going to be home, and then we switch over. So we're trying to also protect ourselves within the team as well, and also less traffic coming into the hospital.
Absolutely. And with the incubation period for this disease, COVID-19, where you could be infected and never know it, or, it may take up to 5 to 7 days before symptoms show up, but you can still get other people sick just walking around. That's a very good preventative measure that you guys are taking. What else are you guys doing to sort of mitigate risk or even protect yourselves while working with these patients that are highly contagious in the hospital?
Well, the hospital's done a really good job of developing, the PPE, the training of it. If we're dealing with any of these patients, how you're supposed to, we're actually changing scrubs right before we encounter these patients. There's a designated shower area that we shower immediately after we take care of these patients, and then change into a different set of scrubs. So we have a very nice, and all these patients are in a room where there's an ante room. So it's a room before the actual patient room. So it's a negative pressure room. So, a lot of different things are done to protect, not just patients, other patients on the floor, or, but also the healthcare professionals. So when we initiate these ECMOs, we actually do it in a 2-person team where one perfusionist that's going to stay in there to initiate the ECMO stays in the room. We don't take anything in there. And as things are needed, they're handed off through the anteroom through another perfusionist. So you're not taking things into the room, and then anything that goes in the room is discarded. And so we're making sure that we also are not wasting resources by bringing everything in the room. So we are using a 2-man system for placing these patients on ECMO.
It sounds like you guys are taking extra precautions while dealing with these patients, which is, I'm sure, very warranted. A lot of what we've been talking about is sort of scary, and it's very serious. And I know that in times of crisis like this, some pretty amazing things happen as far as people coming together and supporting each other. So I'd like to ask, is there anything going on in the Houston area where you're located that has been surprising, or, has really made you and your team feel supported in this time of crisis?
Driving into the medical center and stuff, it's very uplifting to see all these hospital systems. They're putting these massive signs outside, where employees are entering, and the public to see. And, the sign says, heroes work here, you see that, and that's very uplifting. And, the hospitals are really, doing everything they can to cheer employees, that are on the front lines, and also a lot of, local restaurants, and even some of these food chains, they're delivering food to healthcare workers, and so, it kind of helps, both the restaurant industry, and then also cheers up the workers, so that's been very positive and uplifting.
Are there any other areas in which you're getting support that you found surprising, or maybe not surprising, but at least just uplifting?
Yeah, I'm very fortunate. I'm very pleased with the support, leadership support from SpecialtyCare. All the updates we're getting from Tom Coley, all the updates we're getting from Sam, updates from the medical team and Al Stammers, on concerning questions that, we as employees may have. So, that's been very, very positive. I think that, Sam has reached out to my individual employees directly.
Oh, wow.
That are on the front lines. And, I'm getting texts from them saying, wow, look at this, Sam. Our CEO emailed us, and I'm like, absolutely. This is important.
So he's emailing them
important
directly?
work you're doing. Absolutely.
Oh, wow.
And that was extremely, for my team, they were really happy to see that. So that's been very positive. So, there's a lot of, unfortunately, there's a lot of people that are, even in the perfusion industry that are, losing their jobs or having their hours cut or forced to use PTO and things like that. But, as a company, they've done a great job of supporting us. And I'm just very fortunate to be with SpecialtyCare at this time.
Well, Kirti Patel, I really appreciate you taking the time to speak with us today. And I know things are changing day to day, so we may have to do one of these again in the future just to see how things change there. And I hope you guys don't see quite the influx of patients with COVID-19 that New York has.
Hopefully not, but unfortunately, I think we will. And I think as a team, I think we'll be ready for it. So, thank you so much for having me on this podcast.
Absolutely. Thank you so much, sir.
All right. Have a good one.
You too.